الرحيم. الحمد لله والصلاة والسلام على أشرف خلق الله محمد بن عبد الله صلوات الله وسلامه عليه. أولاً جمعة مباركة، وأرحب بالجميع في هذا الويبينار باسم الجمعية السعودية لصحة المرأة. محدثكم هشام أحمد عرب، استشاري أمراض النساء والتوليد وطب الأجنة. Okay, good afternoon, ladies and gentlemen. I think it's time to start. I just want to let you know that there is a chat box here that you can put your questions, write them along during my talk. So at the end, I can really answer them, and hopefully we have a very comprehensive session today. The session today is actually faceted in a way that we're going to cover 3 areas in terms of reproduction, and still we cannot cover everything. Let's start with my slides. So I'll share my slide here with you, and we can take it from here. Right, you can see my slides now. Reproductive hormones masterclass series. I'd like to stop here at the title. Why masterclass and why series? Okay, as a masterclass because it is an interactive session. You're gonna have many expert people attending, giving presentations, giving cases, and also at the same time, you're gonna have an interaction from the attendees. So your attendance is highly appreciated in this series. Being series, that means being held more than once. And this is really the concept of the Saudi Society for Women Health, is really to spread the knowledge. And at least if we start with reproductive hormones, later on we can talk about other things in pregnancy complications, etc., etc. However, let's start with the first 2023 masterclass series for women health, which is the reproductive hormone masterclass. We're gonna hold this masterclass in 3 places. In Riyadh at the Marriott Hotel, Friday, 19th of May, 2023. In Al Khobar at the Voco Al Khobar Hotel, Friday, June 2nd. And in Jeddah at the Radisson Hotel Al Salam, Friday, 16th of June, 2023. So wherever you are, we come to you, all right? Don't miss it. You can register at the Niazic Medical Company, who is really doing the event arrangements. And this is the details, including their phone number, 502111153. And it is a CME accredited. So I'm just going to go through my talk, but I will keep reminding you with this, because when you attend the masterclass itself, it's not just me there. There'll be a whole group of experts along with you, face-to-face interaction, and that is really the idea of having a masterclass series. So in the reproductive life of a woman, actually, we can see that the hormones play 3 parts in her life. From the time of menarche, where she starts to menstruate, this is her reproductive life starts. Okay, and actually menstruation become the major phase of it. In the interim, she might get pregnant. So that's another thing, which is really pregnancy. And then by the age of 50, 51, her life doesn't end. Her life goes to 80 and 90 and more. So there is a stage of menopause where she's not menstruating, she's not pregnant, but she's in menopause. So and we're going to touch all these 3 things except the last one, because I think the menopause in itself has, it constitutes about 1/3 of the life of a woman. Okay, so at least we can have a special session for her. We're going to discuss the 2/3 of her life with the hormones acting, functioning, either menstruating or pregnant. Future session, I promise you, we can come and talk about the other 1/3 of her life, which is in the menopause. Now, the menstruating is obvious, but for the pregnancy, we have two areas that we need really to tackle more in depth. Number one is the implantation. That's the role of luteal phase actually in this area. And number two is pregnancy maintenance. And if it is failing, what will happen? Miscarriage. Okay, so we're going to touch these two things in my talk, plus the menstruation. I'm going to start with part one, which is the menstrual disturbance. Now, there is a new understanding of the menstrual disturbance. First of all, day one of the cycle is not really the onset of the proliferative phase. Remember that, okay? Day one of the cycle is the onset of the menstrual phase. Patients menstruating for about 7 days on average. And then the proliferative phase starts from day 8. Now, at here, for long, again, we have really assuming that it's only the hormones that play the role of the changes in the life, in the menstrual cycle. But it's not just the hormones. Now, at one point of time, there was a question by Professor Finn in 1986, when he actually took some biopsies from the endometrium during the stages of phases of menstrual cycle, and he found there's lots of leukocyte infiltration. Leukocytes mean infection, like inflammation. So he was wondering, what's this going on? I mean, they usually, there are mast cells, matrix metalloproteinase, MMP in the matrix, and the activation persists during the menstrual phases, moving from one stage to the other. So this kind of inflammatory process has been found to be very essential in order to produce a menses, to break down the endometrium at the end of the luteal phase and induce the menses. And also, once the menses occur and all this, I mean, endometrium really breaking down, you need somebody there to clean this up and build again the endometrium. And that's, again, the role of these inflammatory cells. The message has been really, I mean, studied very, clearly in this stage, where actually there used to be antigen presenting cells. They have these cells from endometrial cells being detected by the dendritic cells, which are really the increase in the number during the menstruation, and capture this shed material or fragments and travel to the lymphocytes or lymph nodes nearby the afferent lymphatics, where antigens are presented to the T cells and activate the subsequent immunological reaction that would facilitate endometrial clearance. Now, this is followed by a significant increase in the macrophages to facilitate the endometrial clearance through the antigen presentation and through initiation of an apoptosis to shed fragments. So this is how really the process of menstruation occurring. It's not really just the withdrawal of estrogen and progesterone and menses occur. It's easy to remember for a medical student, but really for the researcher, for somebody trying to understand the exact process, this is what's happening. This is what producing menses. So it's mainly, immunological and inflammatory process going on there. Now, 40% of all stromal cells in the late luteal secretory pre-decidual phase are leukocytes, and you can see here the leukocyte types involved in including the uterine natural killer cells, macrophages, mast cells, neutrophils, dendritic cells, eosinophils, and occasionally even the B cells and the variety of T lymphocytes, and especially the T regular cells. But these are very important because they are the controlling type of lymphocytes for different actions in the, whether it is immunological or whether it is cell type or antibody type. Now, the levels of plasma and of endometrial inflammatory markers, including C-reactive protein, and the cytokines include here is IL-6 and IL-1B, and also the tumor necrosis factor, which have been shown to be of, occurring in a variety of amount. And the levels of IL-1B and IL-6 and IL-8, actually interleukin number 8, have been shown to inversely correlate with the levels of estriol and estrogens, because as this estrogen and progesterone goes down, these actually inflammatory cells would go up. They know that they have now their action has come to clear the endometrium. Now, the irregular menstruation caused by a variety of reasons, include psychological conditions. All right. Higher prevalence of irregular menstruation among women with high household incomes and lower education levels, highly associated with endocrine disorders like diabetes and thyroid dysfunction. So irregular menses is not just something like related to the just for the changes in hormones, but also other cofactors, medical disorders, psychological problems may contribute, and the prevalence of irregular menstruation varies from 5% to 35%, depending on the age, occupation, and the country of residence. And we have seen that in some places they have higher incidence of irregular periods than in other areas. But it is a fact of life where we have seen this kind of changes. Now, but is it a sign of death? It's a strange question. I don't want really to disappoint you here, but ladies who are having irregular or menses, they have shown from this epidemiological studies that the risk for premature death over 24 years among women reporting very irregular or no periods actually increasing up to 1.8 or 1.3 or 1.4 high risk risk ratio, which really a premature mortality defined by WHO, which is the death before the age of 70. So that's what we call premature death before the age of 70, accounting for usually about 52 to 57% million, 70 million deaths globally in 2016. And reports has been shown to be varies from one year to the other. But anyway, this is just maybe a matter of really keeping in mind for women who have really irregular periods, there must be some reason behind it. Maybe that may lead to the premature death, etc. These are just numbers and figures correlating the changes, irregular and long menstrual cycles, whether in adolescence or in adulthood, are associated with this greater risk of premature mortality. This is just epidemiological studies and maybe just explain the correlation between death and these periods. Let's go back to our day-to-day findings in the clinic. Patients having unscheduled bleeding. Every patient come to you with an unscheduled bleeding, you should identify from her, is it a premenstrual or postmenstrual? There are two different categories. So dig into her complaints, ask her again the question, okay, when is this bleeding occurring, this spotting? All right, when did it occur? Is it just before the last period, or is it occurring like when the period stopped 2 days later and it started spotting again? So this is what we call the postmenstrual. Now, we have seen, if you look at this graph, actually, it's very nice to look at the various hormones displayed there. I mean, it's very busy graph, but I wanted to concentrate on the blue one, which is the estrogen curve. Now, the estrogen starts as with day one with the menses, usually drop, but then once the day 7 or 8, when you see the follicles start really to grow, they start produce the estrogen levels will go up and again. But the estrogen is very important for the estrogen actually to go to a very high level just before the LH surge. Actually, it is the you can call it the triggering sign or hormone for LH to be produced, for estrogen to come up very high level. That's the highest level if any of those hormones can reach just before LH surge. Now, you can see that, I mean, rise there is just going up the hill on a very steep mountain. But here, usually you may get some weakness around this mid-cycle, about day 10, day 11. And this is the commonest time when you see patients coming from the post-menstrual spotting. Around day 9, 10, or 11, they start to spot. So that means the estrogen here is failing. And once the estrogen is failing, in the endometrium, signal to it is a drop of blood. And here the failing can be sometimes related to many factors, including the prolactin, which is here in gray, as well as also the ACTH. The ACTH is dropping here, and that's leading to that one. So TRH is also influential here. You have to have an increase in the TRH or thyroidropin or thyroxine a little bit higher at this stage of the menstrual cycle in order to maintain that estrogen rise. So this is a premenstrual. Then going for the post-menstrual. Now, after ovulation, LH surge occurs, of course, and estrogen start to drop again, but estrogen has to pick up again, actually, in fact, during the premenstrual stage, just about the mid-luteal phase, to maintain again if the pregnancy occurred, and to stimulate the maintenance of the corpus luteum. So that increase is mandatory, because if that one, you can see here, estrogen drop, but then start to increase and then drop again. Now, this rise again in estrogen is also needed. And if that doesn't happen and the level of estrogen drop here, as I said before, a drop of estrogens mean a drop of blood. Okay, so here you may have bleeding, which occurring around day 22, day 24, which is just before her menses, when it started day 28. Okay, so that's why we call it a premenstrual spotting. And here, of course, you should know that this is also can be hormone related with prolactin. Prolactin, you can see level of prolactin has to peak again during this stage and then go back to the previous level that started in the luteal phase. But there is a peak of prolactin. There must be a reason for this. And also, in addition, we can see that the FSH3 and the again the TRH really has an effect here. If it drops, if it didn't grow, I mean, if it didn't increase in this stage, then usually that kind of drop make the estrogen drop. And that's why we see this, what we call the premenstrual abnormalities. So this is simply how we can identify the metrorrhagia. Metrorrhagia means a spotting between the periods, and this can be either pre-menstrual, like at this stage here, or post-menstrual at this stage. Now, there are many explanations here of these hormones. I just went through some of them, but usually anytime between day 7 and 24, estrogen drops result in metrorrhagia. As I mentioned before, lower estrogen means a drop of estrogen means a drop of blood. Follicular metrorrhagia, which is really, it is due to insufficient estrogen to sustain the proliferative endometrium, where there is 3 causes of estrogen insufficiency, either reduced availability of peripheral estrogens or insufficient stimulation of FSH and inhibition of FSH. And usually this can be related to the estrogen deficiency or GnRH oxy deficiency. The luteal metrorrhagia, which is the premenstrual, it's usually an estrogen activity declines after ovulation, and it is decline, and if it declines too quickly on a day 15 to 19, there will be the metrorrhagia, and this can be due to the insufficient rise in prolactin, and sudden drop in the GnRH, FSH, and it is intrinsic and due to delayed CRH, corticotropin releasing hormone activity around day 18. Now, if the metrorrhagia occurs in the mid-luteal phase, day 20-21, it is due to insufficient thyrotropin releasing hormone or prolactin to relaunch it. And if it occurs at day 20 to 24, sufficient TRH and prolactin to sustain estrogen activity. So that's why whenever I ask for FSH and LH, I usually ask for prolactin level. And then it doesn't matter when you do a prolactin level, as long as you know when you've done it. You ask the patient when was her last period, so whether you've done it in the in the luteal phase or in the immediate menstrual phase. So this is just kind of premenstrual spotting that's really looked at in different formulation. A study just to look into this when you identify the actual flow. You see the patient, she said, I'm spotting, and then for 3-4 days, and then a flow came in for 2 days, and then it's gone on. So when is my period started? Or sometimes she has the flow and then she kept spotting after that for a few days. Well, really, the what has been confirmed from this study is actually the actual drop of hormones, the actual like mechanism of menstruation is when the time there is a flow of blood. And this is very important. So day one of menses is the day of flow. And this is important. Why? Because this is many questions they come to us from patients asking, I have this spotting, when shall I really start stopping the prayers and then do these religious affairs? I said, well, means if you are spotting, you still can do your perform your prayers, but the mark of onset of the flow of the period is when it starts to flow, and that has been adopted by our religious scholars to identify when is menses occurring. So for menstrual irregularities, we have different ways of managing it. There is a correction of the underlying endocrine disorders to be treated. Once this is established, then men manage cases accordingly. Progestins are the best identified medication for all forms of menstrual irregularity, and it has been shown that the older progestins like medroxyprogesterone acetate, 5 milligrams, norethindrone, NITA acetate, which is 5 to 10 milligram per day, or dydrogesterone, 10 to 20 milligram daily. Or you can have the Mirena, which is really the intrauterine progesterone through the IUCD, and it's combined hormones contraceptives, another option. Non-steroidal anti-inflammatory drugs is also another option for really treating menstrual disorders. Tranexamic acid for those who are having heavy period. Well, I mean, it's important. You can give them this 500 milligram 2 tablets 3 times a day, and that will really help them over 5 days. Don't exceed 5 days. So these are the many options. Okay, but still we have to look into the different modalities, and everybody has his own option when to start where first. Well, of course, if sometimes heavy period, I usually start with the for example, the non-inflammatory drugs like ibuprofen, for example. I tell her take 400 milligrams 3 times a day, okay, or for 4 days or 3 or 4 days. That's it, rather than going straight to tranexamic acid. If that doesn't help, then I'll go for tranexamic acid, and so on. But we have a group, a special group of ladies who are still in the adolescent stage, where this particular group of patients, they need to restore normal menses, does not disturb post-pubertal maturation of the HPO axis. It's very important that drug or medication you use should not really affect the hypothalamic pituitary ovarian axis, and it should not inhibit the ovulation, and it should not be androgenic. Girl will not really like you or love you if you give her a drug that or a medication for her regular cycle, or that will cause hair on her face. So how can we do that? Well, whoops. I think if you come to any of these, you're going to hear the answer from really professional point of view, and tell you the rest of the story of menstrual irregularities, and especially how to handle this in that age. So you can come to Riyadh, Khobar, and Jeddah on those dates. You can take a photo of this slide, and you can keep them, save the dates, and you can join us, you can call us, and the society is really happy to help you out with more details. I need to move to the second part, which is really the luteal phase support. Now, which 3 hormones seem crucial during the luteal phase? I put for you here a slide of the menstrual cycle, and of course, the highest hormones here can be the estradiol, the LH, and the progesterone. For the sake of the luteal phase, of course, I told you earlier on, estradiol need to peak at the value in order to stimulate or trigger the LH surge. So that is number one important. Number two, of course, LH surge, which lead to ovulation. And number three is the level of progesterone is released from the corpus luteum to maintain actually the corpus luteum and then pregnancy if it occurs, and help establishing the implantation of the pregnancy. So from this slide, I can tell you that the luteal phase actually luteal steroids level had really different occurrence when you stimulate cycles. So in the natural cycle, they have a particular level, but when you do ovarian stimulation for any reason, due to weak anovulatory ovaries, usually we try to do the clomiphene citrate, letrozole, or human menopausal gonadotropin HMG, or even recombinant FSHs. Whenever you use any of these stimulatory drugs, usually you'll find that the level of progesterone increases. So it seems to be increases 6 times compared to the natural level, which is 8.5. And the estrogen also increases about 100 times, 50 times during those stage. So that's very important to keep in mind, because whenever you stimulate cycles, you have to keep in mind always you are pushing estrogen levels very high, and that's important, to classify your patients according to that. Now, in ART, assisted reproduction, adding the GnRH agonist or antagonist can help. And the help here, usually, I start with the antagonist. Giving the antagonist with the GnRH, with the stimulation, which is, for example, the FSH, usually reduce the amount of estrogen. Okay, you can see here in FSH alone, 900, well, if it is giving an antagonist, 500. The idea here is to prevent the premature LH surge, and that's why also the level of LH is 1.8 compared to 2.5 if it's given FSH alone. And the reason we want to prevent the LH surge, premature LH surge, is really to have those follicles ready for us to pick up at the time of IVF. Now, low LH concentration during the luteal phase, which is post-STG, actually have been seen in both. And really, the GnRH agonist versus GnRH antagonist, there is a very, very, very important difference between the two, is that whenever you give the GnRH agonist, usually it causes a flare-up at the level of FSH, and here that needs really to be careful, to handle it carefully, which is different from the GnRH antagonist, where they don't have this flare-up, and once you give it, you stimulate immediately, you're actually suppressing the LHs. So here, when using GnRH agonist or antagonist, the high gonadotropin levels suppresses gonadotropin LH, and the progesterone secretion and premature ovulatosis. Abnormal FSH and LH pulsatility can occur, and decreased luteal estrogen, which is really prolonged suppression of pituitary LH secretion 3 weeks and after downregulation, actually can facilitate recovery from the antagonist with the agonist. Now, it seems to be that at the time of the of ovulation, which is in a natural day, if you take a biopsy from the endometrium, you will see no secretory phase. Okay, this is an intermediate at the time of the day of ovulation. Because it's still just ovulation, didn't enter the progesterone that causing the secretory changes. However, in a cycle that has been stimulated by the by FSHs, you can see that the gonadotropin stimulation has caused a little bit of at time of ovulation, clear secretory stages. So that means there is secretory changes that has been started earlier on. And for that purpose, we can say that the advanced and short luteal phase with abnormal progesterone profile that the hyperstimulated cycles, usually they are shorter cycles compared with the normal cycle. So here we don't have the 14 days of luteal phase. You may have maybe just 10 days of luteal phase. So that's why it's very important to keep that in mind, and that the progesterone concentration does not really as much high as needed. And that's why for this purpose, we have seen that in artificial, assisted reproduction, the aspiration of granulosa cells during the oocyte retrieval, because in each follicle we enter with the needle in order to suck that oocyte from inside. So this damage to the granulosa cell, in addition to the use of gonadotropin releasing hormone analogs to prevent the LH surge, in itself that impair the ability of the corpus luteum to produce sufficient progesterone. So automatically, whenever you have a cycle for the ART, for IVF preparation, what you're doing really during the follicular phase by giving the antagonist, and also with damage of the granulosa cells at the time of over pickup, all this really will damage relatively the corpus luteum. So that means the corpus luteum is not good enough to produce enough progesterone. So during the luteal phase, induce the progesterone. Why progesterone? Because progesterone actually induces secreted transformation of the endometrium in the luteal phase. Progesterone deficiency delays the endometrial maturation. Removal of the corpus luteum prior to 7 weeks of gestation leads to pregnancy loss. Normal pregnancy was sustained when progesterone was given after removal of the corpus luteum. So all these old studies, these are facts. It's been known for 30 to 40 years in our science history that progesterone is quite essential. And if you don't have a corpus luteum, you lose the pregnancy. If you supplement with progesterone after removing the corpus luteum, you keep the pregnancy. So all comes back to the progesterone level and its effect. Now, the probability of pregnancy in relation to progesterone level lifetime table, you can see here, this is the pregnancy probabilities, and here is the time in months with the level of progesterone. So the dotted one is progesterone less than 8, and the other one, the stick one, is just really progesterone more than 8 nanogram per ml. So it seems to be the higher the level of progesterone, the higher the probability of pregnancy at any time during the life of a woman, if she's leading actually a normal life and trying to get pregnant. So secreted pulses actually reflected the LH, and within 90 minutes fluctuated up to 8 folds. Now, single sample is not a valid clinical diagnostic tool to evaluate the luteal phase of the adequacy of progesterone. And that's why here, taking just one sample of progesterone during luteal phase is not sufficient. Now, level peak is 6 to 8 days after